but I'll ask the first question. Either of the last two speakers can answer this one first. So I'm a stem cell transplanter. My practice has changed a little bit over the last few years with stem cell transplant and myeloma based off some of the recent data. So in young, healthy patients with standard risk disease, are you who have no contraindications to transplant, are you uniformly recommending autologous transplant to these patients?
Yeah, okay. I was thinking Dr. Ruiz would probably want to go first, but I'm happy to take the question as well. I think, you know, with the data we have, it's still, you know, transplant eligible, young, fit patients, and as you emphasized, Dr. Goodman, standard risk. I think most often my conversation with them is to consider stem cell transplant as a means of consolidation. Yeah. I mean, there's so much data we can go over, which, you know, can be for or against, but it hasn't changed my practice so much yet. But I think in the next few years, we will have some answers as to whether stem cell transplant continues to be the best sort of consolidation therapy versus should we consider CAR-Ts or other therapies as consolidation. But for the large part, my practice for standard risk patients has not changed yet.
And adding to that, of course, there are some changes in terms of the transplant practices over the last few years for myeloma, but it's still, as if you have a standard risk young patient, of course, transplant, early transplant as opposed to late transplant, you know, number one, much better. Number two, you know, some other, you know, we can discuss forever about, you know, the possibilities now with the development of CAR-Ts in myeloma. But it's still, you know, transplant has a significant role, significant place for, you know, for myeloma patients. And in this case, as you pointed out, Dr. Goodman, absolutely, you know, we'll go for transplant, early transplant is the way to go.
Yeah, just because I have just so I want, you know, patients to hear different opinions on this. So there's no right or wrong answer to this, at least in my opinion. And I will say most of the practice is to transplant up front, standard risk, those eligible. I disagree a little bit. I will say that with the most recent data, especially the determination study, and we won't go into the specifics. So transplantation, I want the patients to understand this. So transplantation, although in myeloma, we can get almost all patients through it safely, it still is a big deal. There is a decrease in quality of life, usually for 60 to 90 days around the transplant. You have to sometimes be admitted to the hospital or do it outpatient. And I think the most recent data suggests that we're not maybe potentially improving life and survival with an autologous transplant, meaning total years of life lived, whether you get the transplant or not, is the same, which I think is something we should be happy about. It means that our therapies for myeloma are getting really, really good. Now, that doesn't mean you shouldn't do transplant. Obviously, if you do a transplant in your first remission, your disease will stay away longer, right? I mean, you're giving more therapy. You're giving probably one of the most intensive therapies we can give. And, you know, but does that equate to patients feeling better and having a better quality of life? And that's where I sometimes struggle. I think in our brains, we think that if the cancer stays away longer, we will feel better longer. But it's not entirely clear from the data. That being said, I value a first remission like I think a lot of our patients do. Our first remission is typically the longest in myeloma. And once you relapse in myeloma, it's more therapy, which is not fun to do. So I think it does have a role. But where my practice has changed, and this I do feel strongly on, you know, I used to recommend transplant for everyone. I would have a 73 or 4-year-old patient where I would transplant them. But I was a little bit borderline hesitant on it. You know, I was like, oh, is this the right thing to do? Now I do not. With our current therapies like daratumumab, Revlimid, dexamethasone up front, we can have very long first remissions without a transplant approach. And I might eat my words at this, you know, every decade or so in myeloma, we say transplant's going to go away with the new therapies, and it continues to have a role. I think this time we might get rid of it in the next decade with some of our bites and CAR T cells, but we have to wait for the data to show us that. So that's I
agree, Dr. Goodman. Yeah. I think the two categories which I would first see transplant kind of going away is that, you know, that borderline between transplant eligible and ineligible for whom we always consider, but those patients are whom we can kind of treat with the Maya trial data, which you just talked about, and also our high-risk patients. I really think for high-risk patients, the consolidation with other T-cell engaging therapies are going to come. So in that order, for like the borderline transplant eligible and high-risk patients, I think stem cell transplant may be first supplanted, followed by the standard risk fit patients. So yeah, I think it's going to hang around for some more time, but completely agree.
I think something that perhaps we need to just kind of take into account is I completely agree. The overall survival doesn't change, but something that perhaps I think we're, in my opinion, humble opinion, I don't think we're looking into the right indicators. Remember that transplant is a chronic illness. So as such, as you said, Dr. Woodman, patients are going to live just kind of long-term. And then there are some issues related to quality of life, of course, whenever you get a transplant and so forth. Something that perhaps we can just kind of work on, and perhaps not necessarily look into progression-free survival, overall survival, but other indicators that basically going to give us more ideas as to how patients feel and how patients do after certain things. Remember, bites, CARs also have some sort of significant issues. And for instance, we can argue with the CAR T-cell therapy. Some of the patients, for instance, that were just kind of performing in my institution with lymphoma, believe me, is not an easy ride. And then they get, and some of them, of course, a minority of them ended up in rehab. And then, of course, sometimes what happens with the development of CRS and ICANS, so that those kind of patients of course, have a very tough ride. So my point is perhaps we need to look into other indicators, not necessarily PFS or S, to truly see what are the best therapy for patients. Of course, the more individualized approach as opposed just kind of to look into transplant CAR T bites versus something else.
Yeah, no, I agree completely. The best therapies for our patients make them live longer, feel better, hopefully both.
Right.
And I think with health-related quality of life, which I admit is something very hard to measure, what matters for our patients with myeloma, at least I think, not someone who's living with myeloma, is their health-related quality of life for their whole time with myeloma. Meaning, if the current therapy like transplant improves quality of life for the first few years because they're off therapy, does that offset the decrease in quality of life if they'd gotten a salvage therapy sooner? So, and these are hard things to measure, but I plead and I hope with the community in myeloma that these are things that as our patients are living so much longer and our drugs are so much better, that the field start looking into these things, how to best sequence these therapies, how to de-escalate. And I know the field is getting there with some of the MRD adapted strategies, but we really need to look at how the patient feels for their whole time living with cancer, not just during the therapy they're getting that's being studied in the trial. I completely acknowledge it's very hard to measure that stuff.